lecture. I'm hoping it will record. I hate to do this whole thing and then I play it back and it doesn't. I'm recording this on the Microsoft Teams link because I tried to record it on PowerPoint and it didn't record my voice. So we're doing it here. Let me share my screen. Share machine. So this is the integumentary system, and I'm having to talk alone in the room, which previously at my other lecture for MS, I couldn't get the audio to work, so I couldn't hear you guys for the first group. So I guess it's kind of the same thing. Anyway, this should be quick, easy, to the point. I set it up so that it will answer all the questions that you have for this coming exam, exam 4, and then ATI and NCLEX. All right. Skin cancer. The patho of skin cancer, it occurs due to abnormal and uncontrolled growth. So remember for bone cancer, I explained how the tumor cells overcrowd and they produce too much bone cell. Well, the skin cancer is producing too much skin cells and abnormally. Most common cause, UV radiation, sunlight, or tanning beds. Risk factors: exposure to UV light, so tanning beds, sunlight, fair skin, freckles, light hair. So like I am at high risk for skin cancer, and I actually did have a mole on my back removed way back before rocks were invented, I think around 2008. So I'm always looking around for new kind of skin cancers on my skin. So everybody should be doing a skin check regardless of your skin type, but the risk factor is fair skin, freckles, light hair. Family history of skin cancer. So anybody in your family that has cancer, first degree relative. If you have the similar cancer, you're at risk for a similar cancer. Personal history of sunburn. So one severe sunburn increases your risk, I believe it said, by 50% of skin cancer. So if you've ever had a sunburn that's so bad it blisters, yeah, that you're now at risk for skin cancer. And then also those that are immunosuppressed or have a weakened immune system. My nose is stuffed up. All right, skin cancer. Symptoms. It's based on the type of cancer. So in general, it's going to be a new growth or a sore that doesn't heal, change in the appearance of the moles. Now remember, you've learned the irregular borders, asymmetry, and scaly or rough patches of skin. So skin cancer, and I'll go into more detail for each cancer and what it looks like in a minute. So types. We're going to talk about the 3 types. There's 4, which is some wonky. It's named after a provider, but you're not going to be tested on that one. So just basal, squamous, and melanoma. So, wait, where is it? Here we go. Right here. So basal cell, let's talk about the first one, basal cell. It's going to be small, white, or flesh-colored bump, and it grows very slowly. So when you think flesh-colored, it's going to be the same color as that person's skin tone. So if you're of darker skin, it's going to be a darker looking bump, and it's shiny, pearly looking. It does look like a little oyster, like a pearl, with a rolled border. That just kind of means that it's kind of tucked under, like a mushroom, I guess. If you look at the cap of a mushroom, it's kind of rolled under. That's a rolled border. So it'll look kind of like a little mushroom with a little rolled border. A growth that oozes, crusts, itches, or bleeds, or a wound that won't heal. These are the basal cell. Okay. Here's pictures of it. So if you can see, here's on a fair-skinned person, more pink-skinned, and you can see it's kind of a flesh-colored pink. This is darker skin tones, and you can see here that this is on the darker skin tone, so it kind of matches. So basal cell will look like the skin tone, or it's and it's kind of pearly looking. Okay. So let's talk about the second type, melanoma. That's the one that you learn first, second semester, the very basics, right? That's the one with the A, B, C, D, E. That's the one that looks like the mole that somebody took an eraser to. Actually, let me turn on my camera because you know how absolutely animated I am. So you know you want to see me. You know you do. You just admit it. You know you do. All right. So there I am, just in case you can see me as well. It's sharing that one, right? Okay. All right, so the asymmetry, the border. So remember ABCs. And here's the explanation of them. So review it. I'm not going to go into the detail of it. You guys should already be very familiar with it. And the asymmetry. So here's a little table. Asymmetry, right? The borders or the it's not perfectly round. If you look at a regular mole that's not suspect, it's got pretty symmetrical borders. It looks like a circle. If somebody took an eraser to those edges, that's the asymmetry, okay? Border, same thing. What do the borders look like? Are they spread out or is it very like a tattoo? Is it a blown out tattoo because somebody is a really crappy tattoo artist, or is it a fine line, beautiful looking mole? And then if it is, then there's nothing wrong with it. But if it looks blown out, the border, then we have a problem. Color, right? It changes color. And of course, we always have to ask the patient because how long has that been there? Have you noticed it changes? How fast did it change? So we have to ask the patient these questions. So the color of it, it's going to look kind of this grayish, brownish, purplish, weirdish looking thing. Is weirdish a word? I just made that up. Dimension. So that's also diameter, right? So the diameter, how big is it? How big around is it? We don't want it, remember, anything that's greater than, what is it, 3 millimeters, right? Is it 3? Yes, I believe it's 3. Anything greater than 3, or no, am I thinking, you know what? Google that because I don't remember the size because it's late and I'm tired. So Google that. It's either 3 or 5. I know that lymph nodes are 3, but Google. What are we looking for as far as diameter of it? How big? And then evolution. Has it changed over time? How quickly has it changed over time? Did they notice it? Was it on their back? And they never know it. So sometimes we can't answer that question. But that's the ABCDEs of melanoma. Here's the picture of the melanoma. And you see how they looks. This is exactly the classic presentation of the melanoma. Second type, squamous cell. Squamous cell is flat. Squamous cells, I don't know. You can tell that see, I did this whole PowerPoint for homework. You guys think you're the only ones with homework? I got it too. Squamous cell carcinomas appear flat, reddish, or brownish, and it's rough and scaly, okay? So it's kind of crusty. It can also look like a wart, flesh-colored wart, and a wart looks like cauliflower, right? So if you look at a wart up close, it's kind of got this cauliflower looking. So if you have like this sudden appearance of a tiny wart that just suddenly appeared, you want to get it checked out. Is it a wart or is it squamous? We need to check it out, okay? So firm flesh-colored bumps, don't mistake them for basal, which are pearly, right? Pearly, flesh-colored. These ones are kind of firm like a wart. Here is an example. Hold on. Here's an example of squamous cell. So you notice it's kind of flat as opposed to the pearly that you saw for the basal. And if there's a bump, so see how they're talking about a bump, there's a raised firm lesion. The thing about squamous is it's not going to look smooth. It's going to be crusty. So even if it does have a flesh-colored bump, that flesh-colored bump will be crusty for the squamous cells, okay? So, hey, you could think crusty, crusty crab, squamous Squidward. Yeah, see, crusty, crusty, squamous. So when you think of squamous cell, think of a crusty. All right. Here's kind of the differences. I found a little table so you can see kind of the difference between basal cell, squamous cell, and malignant. Actinic keratosis, that you should have gotten maybe, I guess, 3 or 4 semesters ago, but we won't worry about that one right now, right? Let's focus. Let's focus. Here's another one, skin cancer, identifying it, what the different, what it looks like, right? The different looks of each one of them. So I added that. So the disease progression, early stages, we have localized growth of abnormal cells. And so we're okay with localized, right? We want it localized. We want to catch it when it's localized. So we have to do regular skin checks. They have to see a dermatologist once a year. That's the recommendation by the Cancer Society is dermatology once a year, or at least, at the very, very least, uh, a yearly skin check by the provider. So as a nurse practitioner, that's one of my jobs is to make sure that when's the last time that this person had a complete head to toe removal of the shirt, removal of the drawers, el pato robo mi pantalones, take off the clothes and look all over, especially places that are exposed to the sun, right? So that's going to be the ears, the head, the forehead, the face, the nose, the back, the shoulders, right? The arms, especially in truck drivers or people that drive for a living. Even me with home health, I always spray because I'm so light skinned. I spray SPF every morning. I throw it on my face, 50 on my face and 50 on my body, and I go trucking along. But I still am at high risk for getting skin cancer just from that left arm being near the window. So we want to catch it in the early stages. The later stages, this is the invasive, and it spreads to deeper layers inside the skin and nearby the tissues. So then the advanced, this is where it spreads to the lymph nodes and other organs, and that's metastasis. And that's our melanoma, M for metastasis, melanoma. That's the bad one. So to answer that question, here, let's put this on here, the title, skin cancer. Which one's the worst type to have? Well, from the least to the worst, BSM. That's what I put, BSM. So basal is the most common and the least dangerous. It's very slow growing, and it has a 100% survival rate if we catch it. So if we catch it, within 5 years, it's 100%. You're still alive. The second less dangerous one, but a little bit more, it's less common as a squamous, more dangerous. This one is likely to grow into the deeper layers of skin. So this is where we're kind of getting into what kind of surgery are we going to have. We're going to get into the deeper layers, so we're going to have to dig that sucker out because we don't know where it is. The basal is usually on the top of the skin. We can take it off with cryotherapy, and we'll discuss that. We'll freeze it. Cryotherapy is freezing it, so we can just freeze it, and that will take care of it. But with squamous, more than likely it's deeper layers. So that's when we're going to have to start doing excision and digging the stuff out. And then the number one killer, this one is M for malignant. It's responsible for the majority of skin cancer deaths. This one is the one that metastasizes. If it is localized, if we catch it in time, though, we can do a biopsy, and the biopsy will show, yes, it is malignant, but it has not metastasized. So it's possible to have a superficial melanoma. If we have a superficial melanoma that's not metastasized, but it's malignant. Malignant means that it's going to spread. It's going to spread. Has it spread yet? We don't know. But we call it malignant whether it has or has not, because it has the potential to spread. So a malignant melanoma that's superficial, we can dig that sucker out, and that's our first line treatment. When we find out that sucker has metastasized, it's a little more complicated. But the initial treatment is we're not going to leave that lesion there. So it comes back as malignant melanoma. Are we immediately going to jump to chemotherapy? No. We need to remove that lesion first. So that's the very first thing that we do is we remove that lesion with a very deep excision. It's called surgical excision, and I'll explain it in a minute. Called Mohs surgery. Mohs, melanoma, malignant, mo. Okay, all the M's. So what's the medical management options? Surgical removal of the lesion. This is excision, Mohs surgery. It's the first line treatment of a superficial melanoma. So remember that. Ding, 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 ding. The first thing that we do when we have one of the A, B, C, D, E yucky ones like this, that one, right? That melanoma over to the right. The very first thing that we're going to do is we're going to remove it. We don't leave it there and then do everything else. We remove it. And that's called a Mohs surgery, like Mohs bar. I should have gotten a picture of Mo. Maybe I will in a minute. So Mohs surgery is the superficial treatment of melanoma that is malignant and that will metastasize. So then we have cryotherapy, which is the freezing of the cancer cells, and they use frozen nitrogen, same stuff that makes the smoke, the Halloween smoke, what is it called? Fog. It makes the little fog. That is actually frozen nitrogen. So, or frozen CO2. So either one, CO2 or nitrogen, we put it right on the lesion itself and then we burn it off with cold. The other one is radiation. This is only for localized tumors. So we wouldn't go do this for a squamous, would we? Because a squamous probably could be deeper or it could be spread out. Wait, hold on. No. Forget that, not that. I'm talking about a melanoma. I apologize. A melanoma, we wouldn't use radiation, right? Because it's not a localized thing. It's malignant. It's going somewhere. It's bigger. It's surrounding tissues. It could be involved with huge amount of tissues. So we want something that's localized. So what do we look at a lesion that looks very, neat and pretty and localized in one single spot? That's going to be our basal, and that's going to be our squamous. And you can see right here, malignant melanoma, even if it was isolated, it's resistant to radiation. We don't know why. So radiation therapy cannot kill melanoma. So we don't even use radiation for melanoma. Chemotherapy is for advanced cases. So that's when the metastasis has kicked in. But usually with chemotherapy, just for, if we're saying that it has not metastasized, it's just malignant, it may metastasize at some point, we don't do preventative chemotherapy. So just remember that. There's no such thing as prevention. We'll remove the lesion and then we have to monitor them. Okay. And to see if it has spread or if it has come back. We could do blood tests and find a tumor marker if that's what we needed to do, especially if it was malignant. But usually where it's just a wait and see. So here I did a thing. This is the Mohs surgery, which is a fancy word for surgical incision. It's a very deep. If you look, we have the visible lesion on the top. The first layer is removed, then another layer is removed, then another layer, and then the final. So they're going to do it in steps. So if you want to think about it, there's steps to Mohs bar to get up into the bar, right? You got to step up into Mohs bar. So these are stepwise. So they take a shave off the first bit, shave off the second bit, deep, deep, deep. They are getting everything out. And it's even when they took the one that's off my back, I can show you guys at some point. It was a little mole. It was probably a mole the size, a little smaller than an eraser head, and I'd had it forever. It was a freckle. I'd had it since I was a kid, and then suddenly I could feel it was a big bump. It had grown. The scar is about this big. It's, I don't know, 3 inches long. And the mole itself was maybe 3 centimeters, if that. So that was a Mohs surgery. They dug deep. I had stitches, and it really can cause scars. So you can imagine if you had a malignant melanoma on your face. So I added those pictures. These people had Mohs surgery on their face. So you see these big holes in the nose and her forehead. I got this from a plastic surgery website where they can, okay, I guess, repair the Mohs on the face. But it can leave devastating scars. Not everybody can afford cosmetic surgery, but on the face, you can see how deep the Mohs surgery is. So extensive scarring. So complications, of course, when we're doing this Mohs surgery, surgical incision, infection at the surgical site, of course, recurrence of the skin cancer in the exact same area because we didn't get it all. We did that Mohs surgery and we really dug down deep, to get everything, but we didn't get everything, and then it spread. So the spread of cancer to other parts, so metastasis, especially with the malignant melanoma, occasionally squamous, but malignant melanoma for sure. And then, of course, cosmetic and functional concerns. So cosmetic, now you have a big hole in your face. How do you heal a hole in your face, right? We can't just fill it back up with skin. Or maybe, they did a Mohs surgery on a joint and now you have scar tissue on that joint and you can't move it as well. So those are the complications for that one. So nursing interventions, what do we do? What are they going to ask? What am I going to ask? What's the NCLEX going to ask? What are your patients going to ask? They're going to say, Hey, how do I prevent skin cancer? And remember, it doesn't matter what color skin they have, you always need to teach them prevention. Avoid the sun between 10 and 4 because that's when it's the hottest. We know that because we live in El Paso. No tanning beds. I don't think anybody, I think everybody's smart nowadays. The only time I ever see people with tanning beds is on them reality shows with the really dumb people in the South, and it's the white ladies with the bleach blonde hair and then the orange skin. Yeah, that. So we don't see it as often, but avoid the use of tanning beds. Protective clothing and hats, right? So that's why you always see these old people doing the laps around the park and they always have their big old hats on, and then sometimes long sleeves. I always wonder why these people wear long sleeves in the summer. Well, that's why. Broad spectrum, 30 SPF or greater. Frequent self checks on your skin, and a dermatologist once a year. All right, so we're almost done with skin cancer, and then we're going to go on to burns, and then we're all finished. All right, question. And remember, everything that you need to know for exam 4 is in here. Like, it's there. It's absolutely there. If it was a shark, it would have bit you. So just remember. All right, question. A skin lesion that is raised and flesh colored with pearly white borders is suggestive of which of the following types of skin cancer? A, squamous cell. B, malignant melanoma. C, actinic keratosis. Basal cell carcinoma. What do we think? What do we think? It's D, basal cell tumor. And these are your rationales. Begins as a small waxy nodule, rolled translucent, right? Squamous cell is rough and thickened and bleeds. Malignant is varied in color. It can start as a mole, right? And we can have little lesions nearby. And then actinic keratosis is kind of a dry, scratchy, rough patch without any ulcers. All right, next question. What's the first line treatment choice for a patient who had a superficial lesion and has had a biopsy that indicates, that indicates malignant melanoma is not metastatic? What do we do? What do we do? What's the first line treatment of choice for a malignant melanoma? Surgical excision. I just talked about it, so you guys knew that. So cryosurgery, radiation, surgical excision, chemotherapy. C, surgical excision. And here's your rationales. First treatment of choice for superficial lesions. Cryosurgery is best option for basal and squamous. Malignant melanoma is resistant to radiation. I mentioned that. And chemotherapy can be used as a treatment, but it's often not effective, so it's not the first treatment. Treatment of first choice. So in conclusion, detect your cancer early, improve your treatment outcomes, prevention, and then proper nursing care. All right. Any questions on, I'm recording this, I can't ask you. Any questions on skin cancer? If you have any questions on skin cancer, please either text me or email me or grab me in person and ask me, and maybe I'll know the answer. All right. Next up, burns. Yay, burns. No, not that one. This one, burns. All right, what are the types of burns? There's thermal, chemical, mechanical, electrical burns, and radiation cold burns. What are mechanical burns? Mechanical burns are when, like, rug burn, right? That's a mechanical burn. There's a mechanism that happened to make a mechanical burn. When I was in elementary school, I remember the boys would grab your forearm and twist, like wrap both hands around it and twist it back and forth. And we called it a rug burn, but you can burn that way. Clothing rubbing up against can cause mechanical burn. So that's what a mechanical burn is, okay? Thermal is heat, you know that. Chemical burns, that's acids. Electrical burns, electrical outlets. Radiation burns, if you work at a nuclear reactor or you find something that's radioactive, you can get a radiation burn. And then cold burn, which is frostbite. Ow, 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 ow. So what's the patho of burns? So this is where we have to you really need to know what happens when there is a burn, and especially when we're talking about second, third, and fourth degree burns. So this is going to be the management of a burn that comes into your clinic, into your ER. Okay, the patho in the ICU. So the patho of burns leads to tissue damage and an inflammatory response. So immediately the body is going to do multiple things. So the very first one we're going to talk about is cardiovascular. So immediately well, you know what? Let me do it in this order now that I think about it. Let's start with airway, breathing, circulation. So let's talk about pulmonary. The one thing that we are very concerned about is inhalation burns. Inhalation burns, they can have absolutely zero outward signs of a burn. They could have been lighting a fire, or we've all seen videos of people that put gasoline on a pile of wood and then threw a match and it went poof, right? Well, that superheated air that goes along with that poof of fire is inhaled by that person. So now imagine, you've seen what a sunburn looks on the outside. You've seen what a burn with a blister looks like from the outside. Now imagine what your lungs look like when you've inhaled that superheated air caused by a fire. So inhalation injury, they can be a silent killer. So any inhalation injury is an emergency. They can die within hours. And usually they don't, it's irreversible. They get pulmonary edema, they get that pink frothy sputum, and they basically drown in their own inflammatory fluids. So inhalation injuries immediately in the ER. Okay. The second one we're talking about is cardiovascular, right? So airway, breathing, circulation. That's our cardiovascular, is circulation. We're going to have decreased cardiac output and hypovolemic shock. Why hypovolemic? Because the tissue damage and the inflammatory response causes the blood vessels to be leaky. So everything leaks out of the system and into the tissues. So guess what? There's no blood to circulate anymore. There's no volume in the circulation because everything has now shifted into the interstitial spaces and third spaced, and so hypovolemic shock, because we have no fluid inside the system. It's only in the outside. It's all moved into the outside. So that leads us to fluid volume and electrolytes. We're going to have a fluid shift that causes the edema, right? Because all that fluid that was inside the blood vessels, the moment there is damage to our integumentary system, a cascade of inflammatory response occurs. And all of these histamines release, prostaglandins, everything. And this causes the inflammation, and it tells the blood, which carries all the anti-inflammatories, to get out. And so all the anti-inflammatories, they escape the system to try to repair the injury on the outside. But because the injury on the outside is so extensive, they can't repair and the fluid just leaks out. Okay, so we're clear on that. Hypovolemia, everything shifts outward. So now, if we don't have any fluid volume, our electrolytes are going to go what? Through the roof, right? It's kind of like dissolving the salt in the salt water. Once the water evaporates, you're left with the crystals. Remember, we talked about that for gout too. So what happens once we've dried out the inside of the blood? Our potassium, our calcium, our sodium, but especially our potassium is going to be super through the roof. So one of the hallmark lab values that we see in burns, and this is usually what kills them, is if we do not get that potassium down. They have hyperkalemia, high potassium. And remember, oh wait, in clinicals I said potassium is what we use for the death penalty. That's how we stop their heart, is we give them a bolus of straight potassium. So the condemned guy, he gets his phenobarbital to make him sleepy and fall asleep, and then the very next drug is potassium. They push it, it stops his heart. because it goes into a lethal rhythm. So with burns, they have hyperkalemia because all the fluid's gone, and now on the inside they're really dry. So all those electrolytes are elevated. That potassium is the killer. That's the one that we have to monitor. That's the one that we expect to be high, and that's the one that we have to get down quickly so that they don't die of heart a deadly arrhythmia caused by hyperkalemia. Okay. And so after that, electrolyte disturbances, renal. We have decreased perfusion, right? Because look, our cardiovascular, we now have decreased cardiac output, our hypovolemic shock. So we have no blood flow. And so we have decreased perfusion, right? And the kidneys, they need blood flow into their little glomerulus, right? All the capillaries in the renal, we need perfusion. Once that doesn't happen, the kidney starts to die. So we have to perfuse the kidney. It's super important to keep that alive during crisis, during the acute phase of burn injury. Thermal regulation. They're going to come in with extensive burn injuries. They're not going to have skin to protect them from the outside air, right? Because that's what our skin does. It thermal regulates. If it's cold outside, what happens? We get goosebumps. Our muscles contract and our hair on our skin stands up because that's trapping warm air under it. The hair is trapping the warm air against our bodies. That's the reaction. Now we don't have skin because we burned it off. And maybe we don't even have muscle anymore. Maybe it's all the way to the bone. So we're worried about hypothermia. So we have to keep these people warm. And the way we do that is called a bear hugger. It's it's like a giant blow dryer, but it's blow drying into a mattress looking thing. So it's heated air blown into it. And we call it a bear hugger. And then finally, risk of infection, because what does skin do besides thermoregulate? It protects us from all the bugs. And now you don't have any of that protection anymore. You're going outside without your armor. And so they're at increased risk of infection and suppression of the immune system itself, just due to the shock. So burns, here's the abnormal labs. Tattoo these on your brain. Hyperkalemia, right? Due to the release of potassium from the damaged cells, due to the circulatory volume is decreasing, and now we're really dry on the inside. Metabolic acidosis is what we're going to see because of the fluid shift. Again, because all the fluid's going into the outside spaces, into the muscle tissues, into where it's not supposed to be. We're also going to see an elevated hemoglobin because hemo concentration, right? We don't have the fluid, so everything's getting concentrated. So we're going to see a high hemoglobin because their blood is so concentrated. And then finally, the hypovolemia due to the fluid shift. Remember that. So the plasma leaks into the spaces and decreases blood volume. So classification by death, you have to know this. You have to be able to describe it for the NCLEX. They're going to ask you, the person has a burn that only affects the dermis, and there's redness and pain, the skin is intact. What kind of burn is that? And you're going to say it's a first degree superficial. Yay, because it only affects the epidermis. Then we have a second degree. It's also called a partial thickness. There's two types of those if they don't want to make it any more complicated than it already is. One involves part of the dermis, and the other involves the epidermis. This is intense pain, and I'm going to show you examples of each of these. We have the third degree called a full thickness, extends through the dermis. This is painless because all the nerves are burned off. There's nothing there. First and second, oh, they hurt. Third degree, fourth degree, painless. So an example of the first degree. Now, remember, it's intact epidermal barrier. An example is a sunburn. You ever had a sunburn or you ever burned yourself on the stove without a blister? That is a first degree burn. There's no scarring. So the treatment was aimed at comfort, right? Run it under cool water. Don't put any kind of butter on it. Nothing with oil, because that will trap the heat because you're burned, and it's going to be hot, and it traps the heat, and it prolongs the pain. So don't put butter on it. My grandma used to do that. I don't know why, but yeah, it prolongs the pain. So comfort, soothing salves, aloe vera gel, the sunburn soothing sprays, that. You can also take Tylenol, ibuprofen for the pain and the swelling. Here's an example of a really bad sunburn. Dude's got it on his feet, but the skin is intact. Second degree, divided into two types, superficial and deep. Remember that all second degree burns, though, they have some degree of dermal, and it's based on the depth on whether it's superficial or deep. So second degree superficial, this is where we get blisters. One example would be a scald injury, like, boiling water from a pot or an overheated bathtub. Flash flame burns, where somebody throws gasoline on the fire, but they don't inhale it, and it poof, and then that superheated air burns them. This heals quickly, 1 to 2 weeks, and slight discoloration maybe, but usually it's like it was never there. So this is an example of a second degree superficial. See, this one has the blister. This is after the blister popped. Here's some second degree superficials. They look pretty bad, and there can be some discolorations from the scarring that fades over time. Depends on the size. So then we have the second degree deep, and it's just like it sounds. It's deeper into the dermis. It's going to be pale looking, mottled. Mottled means like it's pale with splashes of red. That's a mottled appearance. If you look at infants when they get cold, their arms and legs, especially white infants, or pink. I always call us pink. I don't think I'm a white person. I'm a pink person. But when you get cold, if you have lighter skin, you can see that kind of mottling, and that's what happens to the extremities. But that's what it would look like. It does not blanch to the touch. So blanch means that we press down on the red spot and it turns white. Then we take off our finger and the blood rushes back, right? That's the same thing we can do with cap refill. That's blanching it. We blanch it, go like this, and the blood returns. It doesn't blanch, but if we poked it with a pencil, or why would we poke it? Why would we poke it with a pencil? I don't know. If we poked it with a needle, it would be painful to pinprick, but it doesn't. It's not painful. Like the touch sensors for softness has been destroyed, but pain, a painful stimuli, is still there. This takes longer to heal. Severe scarring happens here. So this can actually lead to multiple surgeries and grafts. This is a pretty bad one. If it's in the joints, you can lose mobility in those joints. If it's on the face, it can be devastating cosmetically. So here's examples of second degree deep. And you can see why. Why would you scar? Yes, and why? So this guy right here is probably going to need multiple surgeries if he's ever going to use his hands again. If he ever could use his hands again. Or she. I don't know. That could be a woman's hand, for all I know. All right, super important. Tattoo this on your brain. Second degree burns that involve the face, hands, feet, or genitalia or major joints are considered severe and require immediate attention. Okay, so in this picture, you can see the person burn themselves on their wrist, right? But this other person burned themselves on their elbow, but not at the bendy part. Okay, this person burned themselves on their hand. That is a emergency. Okay, immediate attention for second degree. So don't go home and put butter on it. So third degree, now we're getting worse. This is full thickness through the epidermis. It is hard, leathery eschar. Remember the eschar or the Escher that appears on unstageable pressure wounds? Well, this is the same thing. You're going to see a hard, leathery. Basically, what's happened is the skin has turned to charcoal. And literally, you can knock on it and you hear this clack, 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 clack. If you've ever seen pictures of frostbite injury, that's basically is a cold burn. That black where they lose the tip of their nose turns black and their fingers turn black. That is the eschar. That's painless. And you'll also see some black, white, or cherry red skin around there. So just remember, it's painless because everything's destroyed. Third degree, we're going to have the black eschar. There is no epidermis or dermal appendages remaining. Appendages meaning the scaffold that holds your skin together, and then the skin to the muscle and to the fascia. So that's all gone. These ones require excision. So we have to debride it with a surgery called an escharotomy, right? Otomy means to remove. So we're having an escharotomy, and that's scraping off. I had mentioned that, debriding a wound with eschar on it, it's the same thing. Scraping it off, and they're going to need skin grafts. Hopefully not for the rest of their life, but most of the time, if we've gotten to an escharotomy, that area is going to need multiple surgeries because scar tissue contracts and pulls together. It's tight. Scar tissue is very tight, so it's not flexible like the skin. So that's why scar tissue is a bad thing for bendy joints. So the surgical intervention, like I mentioned, we use this for I'll show you 4th degree. People rarely survive 4th degree, but if they end up having eschar or burnt charcoal pieces on their body, charcoaly looking, burnt to a crisp, literally a crisp, then they'll get the surgical intervention, which is the escharotomy. So that one involves incisions through the burn tissue. It relieves pressure, swelling. It allows better circulation and prevents complications. Okay. So the whole reason we're removing that is because we got to save the good tissue that's underneath and the good structures. Here is a 3rd degree burn. You can see the eschar on this lady's face. And you can see this on the foot, the knee. This person is going to look forward to tons of surgery. This hand over here. So we're getting a little bit grosser. So hold your breath for the 4th degree. All right, let's ask this question, shall we? Yes. A nurse is explaining an escharotomy procedure to a patient with extensive 3rd degree burns. Which statement by the nurse best describes the purpose of an escharotomy? A, an escharotomy is a surgical procedure to remove dead tissue and promote faster healing. B, an escharotomy involves making incisions in the burned tissue to relieve pressure and restore blood flow. C, an escharotomy is a surgical procedure to graft new skin onto the burned area. D, an escharotomy is done to remove all layers of the skin and replace them with healthy skin from another part of the body. The answer is B, because remember, we're relieving the pressure and preventing complication. It does not remove dead tissue. It does not promote faster healing. That right there is called debridement. We surgically scrub the dead tissue with soap and water and a scrub brush. So that is removing dead tissue and promoting faster healing. An escharotomy is the one that we make incisions through the burned tissue. We remove that hard, leathery charcoal burned to a crisp part to relieve the pressure and restore blood flow. So here's 4th degree. 4th degree, all dermal layers, all the way down to the skin, muscle, bone. If it's on the head, it's in the brain. It's absolutely painless. And I really, really hope that it's quick if it's painless. Devastating scarring. Decades of surgery if they survive. Rarely survivable if multiple body parts are affected, or the head, or the genitals, or the lungs. So you can imagine the pieces and parts that shouldn't be burned all the way to the bone. So prepare yourself for the pictures. And this is, again, I'm going to say any inhalation burn usually leads to death within hours. So make sure that it's an emergency. I don't know why. Let me put it over here. I think I was trying to put that over here. Over here. Come here. Somewhere. All right. Right there. Okay. I think. Where was I? So there's 4th degree. Brutal. So this person is apparently very dead. This person, I'm assuming, is also dead just by the skin tone of this person, but that is a burned face. This is a person that survived their burn injury. Yeah. And then now has really nothing left of their face. This right here isn't a bent elbow. I know it's kind of stretched out, but that's a bent elbow. So that one is all the way down to the bone. So you can see a 4th degree is basically yeah, you're literally toast if you get a 4th degree burn. So no for the NCLEX, no for the ATI, how to identify what degree burn it is based on the description, okay? Here, you have to know how to do this. You have to look at a diagram and you have to estimate, come back, bro. You have to estimate the burn area. The total body surface area that is affected by burns is called the rule of nines. Okay, rule of nines. They divide the body into regions, and each of them are representing, when you add them all together, they equal the body surface area. Okay, so let me show you what I mean. Burns in adults, rule of 9. We count the head and the neck 9%. Okay, this is on the back of the head and the front of the head. The front of the head is 9%, the back of the head is 18%. The chest and upper back, the chest is 9%, and then the upper back is 9%. So you see how it goes, 9% each, and we're talking on both sides. Okay, so this is front and back. So if we have, let me look at more over here. So here's the estimation. So 9%, head and neck is 9%, each arm is 9%, each leg is 18%, the torso is 36 front and back, okay? So that means what, 18%? So 18% for the front, 18% of the back, so perineum. So know these because they're going to give you this chart. And I want you guys to Google these charts. And they're always going to have something different. But based on the chart that you're given, you need to do the one that's for the American one. So you're going to see legs that are 18%, 14 to 18% on the rules of 9. For the NCLEX, they're usually going to do 18% or 14%, but they're going to let you know on the diagram. So here is the question. Burns. A nurse is admitted with severe burn injuries. Using the rule of 9s, the nurse needs to estimate what the client, what percentage of the surface area. It says to round the answer to the nearest tenth. So this is a calculation. Okay, so this is a calculation. I don't know why it says round when we're dealing with whole numbers, but let's look at it. Okay, here's the diagram. The dark areas is where your patient is burned. So your patient is burned on the front and the back of the lower part of their arm on the right side, right? They're also burned on the front and the back of the entire left arm. They're burned on the chest and the neck, right? This torso. They're burned all the way here on the front, but they're not burned on the back. Okay, so we know our rule of 9s, and I'm going to walk you through this one. Let me look for it really quick. Where is it? I wrote out the explanation, and please tell me that I didn't lose it. Maybe I put it on the other computer. I did. I put it on the other computer. All right, give me a minute. I'm going to have to explain this. Let me get into my cloud on this laptop. All right, let me look really quick. Because I don't know why this one is, of course it's frozen. Okay, All right, I wrote down the explanation, so let me explain it to you because I was like, how can I explain this to you guys on a recorded video? There will be a question on the exam about estimating your rule of nines, okay? So we're going to look at this diagram, and they're asking what body surface area, okay? So they are burned, and because you already know these things because you have memorized them, we've already determined what part of the body is burned. The entire left arm, half of the right arm, and the entire front of the torso. Okay? Our rule of nines say that the head is worth 9%. Is the head burned? Nope. So we don't have to add anything. The torso is 36%. Front of the torso is 18, back of the torso is 18. Is the front burned? Yes. All right, so let's put this on here, The front is burned. That is worth how much? 18. Is the back burned? No. So all we got is 18. Now we know that the arm is 9% each, right? So each arm is 9%, a full arm. So which arm is burned completely? The left arm. So the entire arm is worth 9%, and that is the left arm. That's burned, right? So let's add 9. Now what else? Now that we're going through the arms, right? We got 2 of the arms, so we got to look at the other arm. The right arm is only half burned, right? Half burned. So what is half of 9? 4.5, right? So plus 4.5. All right, now, let me see how I wrote it. Now we're going to go to the legs. The legs are worth 18%. Okay, each leg is 18%. Are the legs burned? No, the legs are not burned, so we don't have to add anything. And the very last one is the perineum, so the genital area, which is an emergency, by the way. Any burns of the genitals, remember, any burns of the genitals, joints, or inhalation, face, those are emergencies. So is the genitals burned? No, we spared the genitals. So that's a 0. So we got everything, right? So we got 9 plus 18 plus 4.5 equals 31.5. So I hope that explains it. You have to, there's no way around it. You have to memorize. The torso is 36%. The arm is 9% each. The leg, those are 18% each. The head is 9% and the perineum is 1. Okay, so if you have to refer back, refer back. They do ask about, let me put this back in, children. Children are different on your rules of 9. So here's the chart for children. So you have to memorize the adults and you have to memorize the children. And now that I think, let me see, 8%, 9%, 9%, 9%. Yeah, so that's true. 18, 18, because that's the front and the back. For children, the head is 18. Why? Because they have a bigger head. Their head is huge. Okay, so burn injuries on children in the head are emergencies because that's, look how big of a surface area that counts for. Kennedy, stop! My daughter is playing murder mystery on Roblox and being very dramatic and screaming. I swear I'm not killing her. So children have a rule of 9s as well, so be familiar with the chart. There's really no way around it, but I'm going to ask you a question on the exam. You're going to have a chart that shows where the burns are, and you're going to have to do the math, okay? got to go through it. Sometimes we got to go up and around the mountain, but this time we just got to go straight through the mountain. Okay. So memorize your rules of nines for children and adults. So the two phases, we came in and we're like, oh, yo, you got 31.5% of your surface area. We know that you're going to be hypovolemic. You're going to be hyperkalemic. You're going to have a fluid shift with edema. You're going to be anemic. You're going to be dried up. So we are going to care for you. And the very first thing that we do is the emergent phase, because there's two. And that's within the first 24 to 48 hours of an extensive injury. And of course, it's kind of easy to remember. Airway. We want to make sure they could breathe. Let's make sure there was no inhalation injury. We need to fluid resuscitate them quickly, right? Because all their fluid is leaving their system, and now their cardiac output's in the dumpster. Their blood pressure is in the dumpster. They're tachycardic because their heart's trying to pump very little fluid. So we need fluid resuscitation. So airway management, if they have to be intubated, we intubate them. If not, we keep an eye on their oxygenation, especially if they are an inhalation injury. We're going to start them on IV fluids and resuscitate them fluid-wise, and we're going to give them morphine. There's no way around it. They're getting a opioid for this one. Remember, this is when they come in with extensive injury. We're in critical care semester, so this isn't just your, I bumped my elbow on the stove. This is the 3rd and 4th degree injuries that you're going to see. So what do we do as nurses? What's our job? We're going to monitor the airway. We're going to assess the vital signs. Remember that we're going to have hypovolemia, so our blood pressure will be low and our heart rate will be high. But once we start that fluid resuscitation, it's going to bump our blood pressure back up, and in return, our heart will stop having to work so hard, and the heart rate will go down. So we know that we have done well in resuscitating them with IV fluid when we see their blood pressure go up and their heart rate go down. So we started the IV fluids. We're assessing vitals again, and we're going to give the medications, opioids. We're going to run the labs. Anything that needs to be done during the emergent care for medication-wise. So then the second one, the final stage, is the resuscitative phase. This one is maintaining that fluid volume and then monitoring for complications afterwards. So this is after 48 hours. So within the first 24 to 48 hours, if you survive that, fabulous. Then we're going to be looking long-term, and that's going to be maintaining your fluid volume because you still have injury, you still don't have skin. So we need to figure out how to keep you alive until we can put grafts on. So what are you going to do as a nurse? Urine output. That's going to tell us about kidney perfusion, right? Because that's important. We got to make sure that the kidneys are perfusing and they're not going to kidney failure. Electrolyte levels, we're going to monitor those. So especially your potassium, remember, and we're going to prevent the hypothermia. We're going to put that bear hugger on them. We're going to make sure that they're warm until they can get a graft or some healing happening. So wound care grafting, when we're talking about graft, just know that there's two types. One is an autograft. That means it's their own skin. So usually what they'll do is they'll take like a cheese, a cheese slicer that you can slice a piece of cheese with. It literally looks like that. And they will take the inside of the thigh and scrape off some skin and then plop it onto the burn. It's as simple as that, really. And they actually they make the skin into like a crosshatch pattern so that it adheres better, I guess. So they'll scrape it off, and then they put this in a little machine that smashes it and puts it in a crosshatch, and then they apply it to the burn. There's also where they're able to grow the patient's own skin in the lab now. So that's a new kind of thing that's happened in the past decade or so, that we're able to use stem cells to replicate the patient's own skin. So just know autograft, auto meaning self, right? An automatic car or an auto-driving, autopilot means self-driving, right? It drives itself. So autograft is self. And then an allograft means it's a donor. So basically, when you die and you donate your organs, part of your organs is your skin. And sometimes we'll just do the allograft first until we can actually harvest it from the patient, because the moment that we transplant a foreign object, substance, organ, we have to take anti-rejection meds, right? The body doesn't like it. It will attack it. So allografts are very temporary because the immune system will attack it as a foreign invader until there's enough good skin while they heal. Because maybe the skin that is going to be good is now swollen and uh, unable to use it surgically. So we have to wait till that resolves in order to harvest the skin. So the rehab phase, what is your priority as a nurse? What are you doing? You're going to prevent contractures. So the scar tissue they're going to have, you're going to encourage range of motion. They're not going to want to bend their elbows. They're not going to want to bend their knees because it's tight, but they're going to have to do those exercises for the rest of their life because they have to keep that scar tissue stretchy. And the way that you do that as well is moisturizer. Lots and lots of moisturizers, pressure garments. So you'll see people wearing Skims. I mean, really, that's what they are, is just a girdle. It's a girdle, girls. It's a girdle. So pressure garments, you'll see if they have facial burns, they're wearing a really tight, almost ski mask looking thing. Depending on where the burn is, we put a pressure garment on. Moisturizers and physical therapy minimize the scarring and then the kind of the results of the scar tissue being inflexible. All right, we're almost done. Questions. Burns, true or false? Hyperkalemia, high potassium level, is an expected finding in a patient with extensive burn injuries. You guys are experts. You already know the answer. That is true, right? That it happens because of the release of potassium from damaged cells and then the circulating potassium as well. So double whammy. True or false? In fluid resuscitation for burns, heart rate should decrease and blood pressure should increase as an indication of adequate fluid replacement. Is that true or false? You guys are experts. It's true. So remember, inversely, when the heart rate increases, the blood pressure decreases. So we want to try to get that heart rate and that heart rate down and the blood pressure up. So if we have that, we have high or a normal blood pressure and our heart rate is decreasing, we know that we have been successful with our fluid replacement. And the reason that we're saying that we're looking at the blood pressure for fluid replacement is because as you move along in your academic career, as you move along in your nursing career, you'll find out that we actually have a formula for fluid resuscitation that involves math. So that's how we can tell if we've successfully fluid resuscitated them along with their vital signs leveling out. But the NCLEX is only going to ask you, and this exam, I will only ask you what happens. How will you know that your IV therapy, your fluid resuscitation has been successful? And you'll know because your blood pressure will increase and your heart rate will decrease. So I added that one. Any inhalation burn leads to death hours later. So just remember that part. All right, we are done. The end. Excellent. So if you have any questions about burns or skin cancer or this lecture, you guys can text me or email me. I hope it wasn't that absolutely dry. I hope you guys learned a lot, and I know that you'll be successful for the exam. All right, have a good night. Let me see if I can turn this sucker off. Stop.